Kimberly.
I'm here.
Okay, I see Siobhan. I see Dawn Meltner. Emily Wang.
I'm here.
Okay, and Rep Nose, did you make it over?
I did.
Okay, so Andrea Foltz, are you with us?
I am here.
All right, that is the entire board and Mr. Nose. Perfect. Good morning, everyone. With that, looks like recording has started. So with that, we will convene a regular meeting of the PEB board. It is Tuesday, May 19th, a little after 10:15. I'd like to call this meeting to order. And the first, of course, item on the agenda is to approve the minutes from April 21st and April 29th. So if we haven't had a chance to look those over, we'll give you a minute here to take and look those over, and then I would entertain a motion.
This is Siobhan. I did read the minutes prior to the meeting, and I move a motion to approve them both.
Okay, so I have a motion from Siobhan to approve the minutes from the 21st and the 29th as written.
This is
I'll
Kimberly. I'll second that. Oh,
Sorry, Kimberly, go ahead.
I will take Kimberly then. I thank you,
There you
Sean.
go.
Kimberly Hendricks, second that. All in favor, say aye.
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 Any opposed? Any abstentions? Okay. The ayes have it. And we are right on schedule at 10:20. And looks like we're going to start out with the 2027 benefit plan, dental, vision, and optical. So I will, I don't know if Andrew or Emery, one of you want to start out and get us rolling. Thank you.
Sure, thanks, Greg. I can start us off here. Good morning, everyone. And so for this portion of today's board meeting, we're going to continue our discussion on renewals for 2027. And so we're going to start with a financial roll-up and composite. This will look a little bit different from how we've looked at it in the prior months, because now we are integrating the results of the medical and pharmacy RFP. And so with our ASPs, those cost projections are now included in the composite. And so we will have a little bit of a clearer picture in terms of projected costs and what that means for the composite rate and overage above 3.4%. And so there are still some negotiations that are happening with the ASPs. And so between now and when we meet in June, there could be some slight changes to the composite, but we don't expect huge changes to come as a result of those negotiations. And so after we've gotten grounded in where the composite sits today with the ASPs included, we'll spend some time having a high-level discussion talking about different scenarios the board can consider to achieve 3.4% in 2027. And so as you'll see when we get to the composite and per prior monthly discussions, currently costs are above 3.4%. And so this portion in section 2 is really pretty high level to start to talk about potential mix of use of reserves and plan design changes and some other things to hit 3.4%. And so when we do meet in June, at that point, negotiations with the ASPs will largely be complete, especially for those items that impact the 2027 composite. And so at that point, our goal is to provide you with the information that you need, a thoroughly vetted strategy, et cetera, to position you all to make decisions in June, make your final decisions for 2027. That said, to the extent that there's a need for a July board meeting to sort of wrap on those decisions, that certainly can be scheduled as well. Those two sections will probably be the biggest part of today's discussion. We are going to do our perhaps final walkthrough for the renewals for the other coverages. So dental, vision, life and disability, supplemental coverages. And to the extent that you're ready, board members, you can vote on those today. Doing so would sort of limit the number of votes and decisions that you'll need to make in June or July. But again, that's up to you. And so when we get there, we can sort of do a temperature check and see how you all are feeling with regards to those decisions. Okay, So I think we can proceed and we'll get into the financial roll-up. And for this part, Emery, I'll hand it off to you.
Thank you, Andrew. Next few slides, we're going to show you essentially the changes in the rates that we have based on the ASPs in this case. We do want to note, actually, let's start out with the statewide PPO. You can see that the preliminary increase is about 2.6% increase over the prior year. So that is a total projected premium just over 400 million. We assumed everybody would just stay in the statewide PPO that are currently in the province statewide PPO. The admin fee increase, we do list 6.2% here. Just want to note, actually, MODA came back and provided a decrease to the admin fee. So that's actually prior to their decrease. We got it kind of late Friday, so we didn't actually update the slide. So the actual admin fee is actually not going to be a 6.2% increase. It's actually, I believe, a negative, but they did provide some savings based on that. For the MODA CCM in that second row, the preliminary increase is 9.6. The admin fee increase, again, we did get the a reduction for MODA, so that 4.7 is not going to hold. But we assumed everybody currently in the province choice and in the MODA regional plans would remain in the regional MODA plan. And so the total premiums there are actually about $750 million, about $750 million. As you can see, the majority of the members will be in that MODA, or majority of the dollars, and property members as well, will be in that MODA CCM plan with the total cost about 1.4 billion for PEBB in total. For Kaiser, they provided a 3.4% rate increase. So based on that, the total cost would be about $268 million. And we did not assume any switching as a result of that. So overall, two of the plans are below that 3.4% threshold, but obviously with the MODA CCM, that is above the 3.4% threshold. And part of the reason why Andrew did mention that the PEBB is projected to be above the limitation, at least currently, for 2027. Okay, next slide, please. This next slide has the dental, vision, and some of the other benefits. We did actually take a look at more recent data for Delta Dental of Oregon, as well as VSP. And so if you compare this to the prior month, these actually are decreases. So for Delta Dental, we do have an increase of 2.1%. I think last month we were saying it's about low threes. So there is a little bit of savings as a result of that. Total premium is about $65 million. Delta Dental, their revised rate increase is 2.5%. So their total premium is $11 million. Willamette, we currently show their 9.5% rate increase. There is a proposal to have 3 years of 3.4%, but we're showing them 9.5%. That's about $16.6 million. And then VSP, previously it was basically flat or just a very small decrease. Now it's about 1% decrease. So overall premiums is $12.4 million. For the next three lines, ASI Flex, BHS, and Weight Watchers, the total projected costs remain the same. ASI Flex and BHS are based on essentially prior usage. And the Weight Watchers is a 25% decrease from about $40 to about $30 per participant in this case. The cap remains the same, however, at about $4 million. So overall, for these benefits, it's about $107 million on top of the $1.4 billion. So total costs are about $1.5 billion projected for 2027. Okay. Any questions before we move on? Next slide, please. So the composite rate. So where is the composite rate based on all of these new elements? Down at the bottom, you can see the 2027. Based on that, it's about $2,020, which is about 6.4% increase. So that is 3 points above the 3.4% limitation. based on our projections, about $43 million above the limitation. So I think prior months we had talked about in that $70-80 million range. It has come down a pretty decent amount to that $43 million, but that unfortunately still is $43 million above the limitation. Okay, so next slide. So go ahead.
Could I ask a quick question? We go back to the previous slide. Sorry, I couldn't get my hand raised quick enough. There continues to be a lot of migration, looks like, to lower cost plans in that second column that after the March census, the deposit rate. Are you attributing more of that to people moving into Kaiser deductible? And did you build in some of that into the 6.4% renewal?
We do not change enrollment from what we have based on the March 15 census in this case, because the projections are, or the costs, the official costs are based on that census. We apply that. We did not assume additional switching into, let's just say, the lower cost plans with, the Moda Regional or Kaiser deductible. In this case, we just wanted to provide a snapshot. So no, we did not. I guess to answer your question.
Okay, thanks.
Yeah, I know in past, well, was it, I don't know, at least 10 years ago, there was a, I think, assumption that was built into what the PEBB board had voted on, but I'm not sure that's allowed under the current limitation, but it's been a long time since that's been done. Siobhan.
I just want to make sure, Ollie, are you suggesting that it might be lower, like the 43.4 million might trend lower because of that migration?
Yeah, I mean, it's a little bit different with the RFP. I think in the past, the board's incentivized members to move to lower cost plans. And I think, as Emery said, I think at one point we built in some migration factor into the renewal, the composite rate projection. And I just noticed a pretty big drop off there with the 2026 final numbers. So I was just wondering if that would be possible, but understanding again, it's an RFP, so plans are changing. So it's hard to forecast that.
Sean.
Yeah, just on that point, I was thinking about that earlier on a few slides ago when we were looking at the CCM, and the assumption is that, that the MODA CCM would be consistent. I mean, that's the assumption. It's built into the model. But we don't really even know what that CCM exactly looks like at this point, because we're still negotiating, like, what is the lower cost plan and what does it do? So I'm not saying that's wrong. We have to make some kind of projection. And also, there's this year in particular, there's more flux, I'd say, about assuming who's going to switch to what thing, because there's going to be a tremendous amount of switching. And we don't exactly know at this moment what exactly the CCM is going to particularly look like, or why is it a lower cost plan compared to the statewide and so on. It's still being developed. So that's quite the variable there. Because
Sure.
To Ali's point, that's a big variable. I'm not saying we don't have a problem overshooting through. I'm not saying that. Let's just be clear. But I'm like we have to land the plane and we have to follow the rules, and also I'd be surprised if it's exactly 43.4 million, right? Because of that flux that we don't really know. So anyway, for whatever that's worth, we can't really work with that, but it's just a part of our variables.
Yeah. Great points.
Yeah. So, I mean, every year, I think PEBB has pretty much reaped the benefits of people switching, and that helps the following years. increase, I guess, if you try to accept it now, you wouldn't be getting it in next year. So you're just kind of shifting the time period where that benefit's being impacted of this switching. Okay. Next slide, please. So one thing that we did was to take a look at the RBC and to see what, with the most recent experience, where all the claims and everything's kind of coming in. If you wanted to, on the left, we did kind of restate the 2025. It's actually an improvement. So the ending RBC is now, or is above the target, above the range. So there's more dollars in the reserve fund. And that does impact the results for PEB moving forward. So if you compare just the prior RBC analysis, like the one in February, you can see that it's actually been, it's better. For 26, there's an improvement of about $33 million. So part of that, the costs were improved by $33 million. So some of the lower claims that you see reflected in the rates from prior analysis is now being shown here. And then the improvement for 2027 is about $43 million. So even with no essentially plan design changes, if everything was done on the buy down basis, you'd still be in that range target for 2027, but you would be below the target. And then, but that does compound when you take a look at 28 and 29. The target does increase to about 333 million and then 356 million in 2029. And you can see the funding balance without any changes would project to decrease because trend is expected to increase more than the 3.4%. So just kind of keep in mind, you're in a decent situation for 27. But if the more reserve usage you have for 27, the more it's going to impact 2028 and beyond, the more changes you have to do. So it's when do you want to address the issue? Sean.
Yeah, could what for the mustard line, what trend rate assumption is it built on?
Yeah, it's based on what the market trends. So overall increases, I believe, in that mid 6.6, 6.7%. It is, weighted with dental and vision, so that kind of brings it down a little bit, but generally it's just the medical trend increases. So it's close to 7.
Somewhere around 7.
Yeah. Okay. Yeah, and those trend rates we haven't changed from February. I mean, actually, I think we kept them the same from prior year as well. So it's been in that ballpark. Okay, so this gives you a snapshot where the RBC and the fund balances are. If you go to the next slide. What we want to do is kind of give you a table where you can see basically what would happen for 27 and 28 if PEB decided to kind of go between the range of using all reserves to making all plan design changes to meet that gap to the 3.4% limitation. So we are talking about $43 million. And so that in the second column, we talk about the reserve usage, 42.6 or 43 in that ballpark compared to 0 reserve usage. So, you could use 42 million, you could use potentially 25 million, 12.5 million, or basically no reserves and just do plan design changes. And so what would that impact be on the ending fund balance for 27 as well as 28? So, the first column on the 27 is really kind of just showing the result if you use different reserve levels. And then the third column is the amount of plan design changes that would be needed to essentially fill that gap. So it goes from $0 plan changes in top row, but if you do all plan changes down at the bottom, it's 42.6 million. And that's about 3% plan design changes on the medical plan. Sean.
And am I understanding right that we got some inquiries that seem to indicate that legislature is considering sweeping this again?
Holly?
Yeah. I haven't heard that specifically.
I haven't either.
Yeah,
okay.
But I've been
Just
asked for balances from CFO and from LFO, legislative fiscal.
I mean, I'm sure that's a thing that people routinely ask for, but like
it is.
Okay.
Yeah,
Yeah, I wouldn't associate ill intent with the request because they do
All right,
always
all right,
ask
all right.
for the request, but yeah.
Fair enough.
Hey, but
Just checking.
just since you mentioned it, if this starts to take on a little bit of some life other than the normal, let me know.
Likewise. Thanks.
Okay.
Um,
Okay. Back to the regular programming.
Yeah, thanks.
Yeah, so I mean, yeah, right, Sean. There's been sweeps in the past, right? Whenever the balances do get a little bit higher, that's obviously been a concern of the PEB board, and so some of your decisions, at least on the reserve usage, might be, I guess, impacted by historical historical actions, but just want to kind of give a kind of picture of the different reserves and then the impacts as well as the plan design changes and then the impacts on 28. So if you take a look to the right, you can see the 28 ending fund balance. The target again is 333 million. But the more reserve usage you use now, the more the 28 fund balance, at least without any changes, is going to kind of go down. And so with no plan changes at all, the top row in 28 on the third column from the right, your ending fund balance is 194 million, which is 140 million below what we would say is a target. The deficit itself for 28 and the gap to the 3.4% would be 6%. So you would need to make 6% of plan design changes in that instance, or spend down, which you are running out of money because it's on the prior slide in 29 you are like at 40 million without any sort of changes in that case. Using the second row, we're used $25 million, so more reserve than plan design changes. So it's about 2/3, 1/3 reserve usage. That does put the ending fund balance at about 230 million in that ballpark. The deficit and the plan design changes, you still have to make about 5%, 4.8%, because we are talking about 1.2%, 1.1, 1.2% in plan design changes in this case. The third row, which has more plan changes than reserves, there's about 2% of plan changes, and then $12.5 million of reserve. That still potentially puts you 4% over the 3.4% limitation. So kind of a little bit worse situation than we currently are. So you would have to then again talk about what you want to do to meet that 3.4% limitation. And then the final one, all plan design changes. So you do save money. Your fund balance kind of improves in 28. It's a little bit definitely healthier at 280 million, but you still would have a 3.3% gap, which to Sean, to your point, it's the delta between what we're seeing as trend for the benefits versus the 3.4% limitation. So hopefully this kind of gives you an idea of the impacts on 27 and also how, whatever you decide potentially would impact 28. Obviously, we're not asking for a decision now, but kind of gives you a sense of what's happening in this case. Any questions, comments, thoughts? We do target, we will show on some of the future slides kind of essentially what 1.2% and then low 2% in terms of plan design changes mean. So it kind of gives you an idea. So hopefully I'll provide a little bit more context around what's being, I guess, proposed or at least shown here. Okay, next slide, please. So plan design changes. We do show for each plan some plan design changes. As mentioned before, we have option 1 and option 2. Option 1 is the smaller plan design changes. Status quo would obviously be current, which is on the left, but we do show some proposed or potential plan design changes to get essentially a little bit over 1% and then about 2% in option 2 of savings. Siobhan, go ahead.
Yes, I'm hoping that you can just explain a little bit about how Garner would intersect with the deductible and out-of-pocket max in options 1 and 2, so we're all clear on it. And then the other piece that I just want to continue to keep in mind is with Providence going away as a choice in 2027, we're going to have a lot of people experiencing formulary changes around pharmacy. And what that might look like for folks if we increase deductibles, knowing that there's just going to be a lot of change. And this is going to be true for statewide and the other plans as well when people are moving and how that impacts their prescription choices.
Yeah, we can definitely do that. I think with the pharmacy, all of the people in the self-insured plans are going to have some sort of change probably, right? Because everyone's moving over to Capital RX. And so the formulators are going to definitely change the processes, the part of, those sorts of things. I mean, there's going to be some transition and things like that, and we can talk a little bit more about that later. I don't know if I want to get too much into it, but there is definitely going to be some change there. Yeah, so there might be, I guess, less of an appetite on the deductible, especially if we're talking about deductible changes for pharmacy, especially since we're not talking about big changes here. We're not really recommending big changes or any changes on the copays. In this case, we're kind of like, well, you can kind of keep those steady because we don't need that much more. So those savings down below are kind of small, but we just kind of wanted to give at least a sense of what that would impact. There is definitely going to be a lot change. So, in addition to that, having a little bit more to pay first dollar, that's something the board's going to need to assess and decide whether you want to do that. But there's definitely some more change, and we can provide more information about that as we work through all of this with the Capital RX. But for the medical, we do have some options here, and with the deductible, so these are all kind of together. The deductible out-of-pocket max, and we did put something here, an additional cost here for conversation, whether you want to do it or not. It's I don't know, it's a possibility, especially with having a Garner in there, which reimburses the out-of-pocket maximums, whether you want ways to incent more usage of Garner potentially. But with deductible, we have option 1, option 2, where we do increase by $100 per member, and that does go up to $300 for the families, or $250, essentially a doubling in option 2. This is for statewide plans. That's one of the potential impacts there. And then one out-of-pocket max, increasing that by a little bit, or some, $450 on the option 1 per member, and then about $600 for option 2. And that out-of-pocket max increase does include the deductible increase. So it's not just pure. So part of that deductible increase would go to the out-of-pocket max increase. But these are some potential options that would get you to the about 1.2 and 2.3 million percent in savings. So you can see the dollar savings down below as well. So this kind of give you a sense of what we're talking about when we're talking about 1 to 2% plan side savings.
Okay, and Emery, I'm sorry, I'm just not quite tracking. So if we went with option 1 or option 2, people's deductibles would go up, but they would get reimbursed if they were using Garner, and they would pay them up
we're
front,
not recommending. Yeah, we're not recommending any change to how Garner works, except for this additional cost here. So, generally for services, and not all these. I mean, we're kind of throwing these out as potential things to consider. We're not saying absolutely do this. We just kind of want to get your sense of it. But Garner would not change in terms of how it currently works. So if you go look for a Garner top provider and use that provider, and your dollars are your like super service of the year, and so the deductible applies, you would get reimbursed by that up to whatever deductible is. So let's just say you go and have a surgery, right? You look up the Garner provider and use that Garner provider, top provider. In option 2, all $500 would be covered under that HRA, assuming you have that amount in your HRA, in the Garner HRA still. So all that dollars would be covered in this case. So the way Garner works wouldn't really change in that case. All the out-of-pocket costs would be covered up to your whatever the benefit is. So that's not changing. The one thing we toss out here with additional cost here. So the additional cost here, for those who kind of don't remember, it's a copay that's applied if you say go and use a preference sensitive service or service that might be not as high on essentially prioritized services list. So let's just say I'm just going to use this as an example. If you were going to do bariatric surgery, so there's additional cost here as a result, and so you pay a copay. I think I don't know, it's $100 or $500 depending on the service that you use. So this to incent extra use of Garner potentially, you could say that, hey, even if you use Garner but you don't go to a top provider, the additional cost here doesn't apply. So people would then sign up for Garner, get used to using that get used to using the app to look for a provider, and then make that decision whether it's worth it to them or not. So it's just kind of like a way to maybe incent it. There's not that much usage of hopefully of some of the services with additional cost here, but it kind of gets people to think about it and to potentially use Garner more in this case. And then that maybe they might use Garner for other services and then go to those providers and then increase usage and save money for pet. That's just one possibility. Sean.
Yeah, just on that note, I think in general, we have tried when we've been in the corner like this before. We have tried to find ways of increasing costs when we have to members with a purpose. So whenever possible. So like if you increase a deductible, there is no purpose to that other than saving, like cost shifting. Like it doesn't do anything. Like it doesn't create a behavior change of any type. It's just like, yeah, you can't avoid that, so we're just shifting some costs. So not to say that we can't do it or shouldn't do it. That's why it saves so much money for the plan, is because you basically can't avoid it. But where possible, we've tried to be more intentional about cost shifting. So if we have something, in this case, Gartner, where we're trying to channel people, direct people, then there's theoretically a way for people to avoid or at least mitigate some of the cost shifting we're doing by having an option. Now, they may still choose not to do that because they're like, no, it's worth the cost difference is worth it to me. At which point, fine, they had some choice. It's like, okay, that was your choice. But at least they had a little choice, they and it kind of directed them towards something that was beneficial for us both, which is cost saving. So anything that we can do in that direction, and again, I'm not saying that it's totally out of the question or anything like that around deductible. It's just a blunt instrument, which is why it's always been the last resort, because it just kind of doesn't do anything other than just shift some costs. And so just keep that in mind. I guess I'm encouraging you, Mercer, to just like, as we're further finalizing things or proposing and whatever, it's like, in my mind, it's more palatable to discuss cost shifting when there's a little bit of a purpose to it and people kind of have some choice. Like, well, I could take on those costs, or I could do this, like whatever, more restricted, this and that, it has a system purpose. So anyway, that's all I'll say about it. It's just a general comment for later.
Yeah. And Sean, back, I think in 2012, I think that's the last time the deductible has changed for these plans. And when those deductibles were, I think, implemented, but please correct me if it wasn't just implemented, it was increased. But there were definitely lots of behavior change, at least in the initial years. So that eventually went away. But there definitely was some behavior change as a result of seeing that your deductibles increasing and utilization went down a bit. So I do think there is some sensitivity to that. one thing that we have presented in prior meetings with benchmarking, again, deductibles haven't changed for like 14, 15 years, right? Costs have gone up. And so the impact of deductibles keeps going down. And so there might be something to kind of recognize the fact that costs keep going up. That said, one of the options I think Garner has talked about, and I think OEB's talked about this, and we can talk about for PEB as well. If the deductible increases, you get more value, I think, out of Garner if you kind of do kind of a double, where it's like the deductible increases and your HRA amount increases. It kind of increases the value of Garner, right? And so that increases the usage and incentive. It makes it more valuable to members to use in that case. And then you get the downstream impacts of going to more efficient providers, better providers, and stuff like that. So that is a potential option to talk about, whether you want to play with the Garner incentive if the deductible or out-of-pocket increases as well. So that would be help mitigate some of the cost increases for those members who are cognizant of using Garner and trying to find those providers versus just a pure blunt instrument of we're just going to charge you more for a deductible and out-of-pocket.
Yeah, I mean, I think it's worth discussing. I mean, I think Siobhan kind of hit the point, right? Which is like when we say behavior change, what we mean is a good behavior change, you know?
Mm-hmm.
So like, if people use their medical benefits less, maybe that's good if you believe that there's overuse of medical services, but maybe it's not good if people are avoiding going to the doctor when probably would have been better had they, you know? So it's just like, it kind of depends, you know?
Yeah. And we're not recommending any changes to the way the first 4 PCP visits, right? Those are not subject to deductible. We're leaving that. We're just increasing the amount that the deductible is. So that sort of, I guess, I don't know, incentive for better use, right? Visiting your PCP if you have a chronic condition, that's still going to be there.
That's good to know.
Siobhan? Yeah.
Yeah, and just as we continue this conversation, it would be helpful. We've had, such stressors with collective health and Providence. It's more of a challenge to see what Garner looks like. And Ollie, I don't know if you have insight, because OEB adopted this as well, and whether we can look and see what it looks like for MODA. Because certainly we wouldn't want people to go through another collective health type debacle like when they change health insurance with Garner, right? Like we would want to feel confident that it's working well. So, I don't know if Ollie has insight.
Yeah, I was going to say things have actually been working extremely well with OEB and Garner. So yeah, I think administratively, no concerns there. But yeah, obviously things have, even with PEB, I think Garner's been really risen to the challenge and done a very good job.
Yeah, and it's still pretty early to say what kind of financial impact Garner's have, right? But as I mentioned earlier, I mean, taking a look at the claims, at least for first quarter, I mean, I think it's looked like, at least for MODA, like has maybe improved. So I think there's positive signs there. There's definitely not any negative signs. So hopefully it is providing some value in this case. Emily?
Yeah, I was just going to add, we're on MODA. We switched from Kaiser to MODA, and then I picked a primary care physician, a naturopath, and she happens to be one of the top ones in Garner, and I have already gotten reimbursed for going to my first visit with her. And I've heard some of my colleagues at Oregon Health Authority also say, wow, I just got reimbursed, for going to Garner. So, I mean, that's not, it's not a research study, but initially, I'm having a good experience. So thanks.
Thank you.
Yeah, I'll
yeah,
add
so
that
go ahead.
I've gotten good feedback so far from a few coworkers as well who have, kicked the tires. So like at least some small number indicators that it might be working. See.
Yeah. Yeah, I mean, we have monthly calls and we get satisfaction information and stuff like that, and we'll talk about it a little bit more, I think, in the IWG as well. But yeah, we're gonna hopefully keep on top of it, and hope. I mean, I think the feedback has been pretty positive, at least from what we've heard. But with these plan design changes, I think this is also kind of like I don't know if it's kind of for awareness, right? It's like when we're talking about what kind of changes are needed in order to make some savings versus reserve usage. This is kind of hopefully edifying to the PEB board, right? In terms of giving you an idea of what kind of changes we are talking about if we postpone stuff and have to do things bigger, long term. The type of the size of the impacts that might be necessary. So anything we can do to help defray costs to bring down the trend now is going to be help mitigate some of these changes later on. So, but just wanted to kind of provide a little bit of education. The next slide is going to be very similar, except it's for the Moda Regional Plan. So we can move to the next slide, please. Thanks. So the information here is kind of the same. We did increase a little bit more on some of the stuff. So just to kind of provide a little bit more savings. The deductible, you can see we actually kind of kept it at $350 for option 2, but we did impact the copays in option 2 more than option 1. So we just kind of want to give you again a look at potential of what would be needed to save 1.2% or 2% in this case. So deductibles would be increasing from $250 to $350 under both options. And we can play with all this information or all this based on your feedback as well. But then out of pocket would have another kind of increase as well, $250 for a member. So another $150 on top of the $100 deductible increase for both option 1 and option 2. But the real differentiator in this case is really the copays. So we would increase the copays to $15 or $20 for PCPs. You can see that in row 3. And then for the specialist copays in row 4, we start differentiating potentially in option 2 between PCP and specialist. So maybe kind of trying to show that primary care would be more important. Primary care does include BH, so behavioral health and substance abuse would be covered under that lower copay in this case, but kind of showing a differentiation between the two in option 2. And then the other difference here is just really kind of like the inpatient hospital, right? So the cost of an inpatient stay would increase. Not everybody has these, but they are costly, like $30,000 plus per admit on average. I think it's like mid 30,000. So we are talking about an increase from potentially $250 maximum up to a $500 maximum. So just kind of ways to kind of potentially save a little bit of money here. And then down below, you can see the pharmacy impact of the deductible increases of $25 and $50 per member.
And Emery, does the Garner work the same way? Like with the inpatient hospital and specialist copays? Yes. It would?
Yes.
So people could potentially get reimbursed for that too if they had their procedure done. Okay.
Yeah.
Thank you.
Yeah. So you can definitely get reimbursed that way. Another thing, we're talking about trying to differentiate regional plans from the statewide plan, and drive members. I mean, one thing is the Garner incentive is the same on both. Maybe you kind of differentiate the Garner incentive in the HRA amount that's available. That's possibly one way to drive members between the plans. It does impact potentially. Go ahead.
Oh, no. Sorry. I just saw that Andrew also commented that Garner applies to the pharmacy too.
It does. If the prescribing provider is a top provider, any prescriptions that they write is eligible for the reimbursement.
Yes, I was reimbursed for one of mine. Yep. Go ahead, Sean.
I'm just thinking about the pharmacy comment. So given this next round that we're talking about, we'll have a new pharmacy, you know, program. So, people associate things, even though they're non sequitur. So it's like, oh, it's a new plan and it's more expensive. And it's like, I hate the new plan, you know? So I just kind of want to flag it in the, I don't know if there's avoiding that per se, because actually everything's changing and a lot of people will be switching and then it's more expensive. And then it's like, I don't like it, because but I'm just flagging it, to not
Yeah.
poison the well, just because people associate the, change, and it's like, well, both things are changing, therefore it must be the same change. And it's like, actually, there's two different separate decisions. But anyway, just for whatever it's worth thinking about, like, do we want to hold some things steady so as not to start off on the wrong foot versus other things where it doesn't look that way? I don't know. So.
No, that is definitely a concern, right? You don't want to correlate capital RX with increased cost, right? And I mean to the member. You're poisons their the image, or like the view of the member's view in some cases. So yeah, that's definitely a concern. We did show it just kind of like as a kind of like an increase because the cost pharmacy keeps going up, right? Just kind of like a something to think about. It may not be something that the PEB board wants to do. There might, and the dollar savings aren't that big for the deductible increases, but just kind of wanted to show what's possible there. Yeah. So, okay. I don't know if there's any other comments or questions, but basically, on these self-insured plans, we did want to kind of give you a sense of what 1% or 2% in plan design changes would be on the medical to kind of tie into the 3.4 scenarios above. Okay, we can move on to the next slide. So this is for Kaiser. We do show the deductible plan up top and traditional down below. One thing that we asked of Kaiser was to give us pricing on plan design changes that would essentially move essentially similar dollars, right? Or percentage savings. 1.4 and 2.5 was what Kaiser came back with. And they came up with options. You can see the copays there for option 1 and 2 for the deductible plan. They would increase from 5 to 10. That third row and of both the deductible and the traditional, that says virtual. It's actually the vision plan. Kaiser's vision, that shouldn't say virtual, it should say vision. The vision plan is integrated with KP. So if you go and had a vision service, that would go from $5 to $10. Siobhan.
Was Kaiser willing to differentiate between the deductible and traditional? For example, keep the current copays for deductible, current RX, and increase them for traditional? Because the traditional plan is so much more expensive. So just curious if they were willing to present that option.
We can definitely go back to them. I mean, this was we can definitely go back to them and see what they are willing to say. We did get these options, I think, late last week. So we haven't had a chance to do that. Andrew.
Yeah, the other, Siobhan, I think we have looked at that in prior years. So I think it's a good call out. But the other correction here is that I just wanted to call out that outpatient surgery copay change is currently listed in the deductible plan that actually is proposed for the traditional plan. So that would be an example, Siobhan, of changing the outpatient surgery copay on just the Richard traditional plan.
Yes. Yeah. So, Kaiser, the deductible is $250 for Kaiser. There's no proposed change there. Traditional plan does not have deductible. There's not a proposed deductible to be implemented for traditional plan. So where would the plan changes come? It would be essentially from copay changes. So those changes and changes to the pharmacy for deductible under option 1, no change, but you would increase it for option 2. And a similar story for the traditional plan, where the copays for the RX would be the same for option 1, but increase for option 2. But you could get some savings based on the copay changes. Go ahead,
And I
Sharon.
just want,
Sharon.
and I just want to make sure I was tracking correctly. So the option, what the copay changes that are proposed would make the Kaiser copays the same as the current copays are for MODA, is that
Yes.
right?
Yes.
Okay.
Yeah. So the Moda regional is currently 10. I think we explored that a while back, especially when the copays went up, but Kaiser did not increase theirs, or the board did not elect to increase the Kaiser copays. So yeah, this would have parity unless you change the copays on the Moda plan for 2027. But this would get them to where they are. Yeah. So with those were the medical plan design changes that we wanted to show. Again, tying into those different scenarios with the percent changes. If there's any feedback, I mean, we've heard some really good feedback on where you think things should move. But if there's any other feedback on where we might want to explore, any other things that you might want to talk about, please let us know. Because I think after this, we do move into some of the other renewals where we have some board action that's going to be requested. So if there's any other thoughts on essentially, getting to 3.4%, would open up the floor if there's any other comments.
I guess I'm just curious, like the Kaiser deductible plan is currently our lowest cost plan,
Yes.
is that right? And so I would
Yep.
just be, I mean, we've talked about migration before and people get good coverage under the deductible plan, and particularly if they are paying a 1% premium share. And obviously people's particular circumstances matter. And for a lot of people that deductible amount is made up in the lower premium share. And so just thinking about incentivizing the deductible plan and people migrating to that plan. So I'm curious to see if Kaiser would offer up a differentiation between the Kaiser deductible and the Kaiser traditional.
Sure.
Yeah, I agree with Siobhan. Also, there's the old classic ER visit, copays. So just there's a little bit of purpose there to try to disincentivize, going to the ER whenever you don't really need to go to the ER. I don't know how big of a problem that is anymore because access to urgent care is broader now. But there's that, just for the sake of options.
Yeah, definitely. We can take that back. I know guys are on the call, right? So we'll take that back and we'll have those discussions. There is one thing with in the proposal that Kaiser had, they did provide like a multi-year premium rate increase, but I think it's contingent upon no plan design changes. So I think they did note that it might go away. So we'll have to have that sort of there might be some ancillary results, changes that might have happened as a result of this.
A rate hold? Is that what they were proposing?
Well, it's not a rate hold. It's it's like a proposed 3.4% increase, maximum 3.4% increase if certain conditions are met. So that might go away as a result of plan design changes, but we'll have to have that discussion. Okay, this is the last slide we would have on the 3.4% and different plan design changes for medical. If we don't, I think we can move on to no more comments. We can move on to the next section. And Greg, Chair, we're doing okay on time. Is there a break scheduled?
We're looking at a break at about 11:35, but if we push a little bit,
Okay.
I know we have some of these to go through here and probably maybe some votes on them, but let's see where we get.
Okay. All right. So as we go through the renewals, and we're going to ask for board action. We don't have that listed on the slide, but basically we are asking for board action to essentially approve the rates for the standard in terms of the life and disability. We show these rates here. They're the same as last month. They are improved from the initial renewal, where there's a little bit more reserve usage to bring down the rates. So up at the top, the basic life, that does impact the composite rate, but we are talking small dollars here, or actually less than $1. So you can see that the basic life active rate is about currently 16 cents per $1,000, and there's $10,000 worth of benefit, so that's $1.60. There's the proposals to decrease that by 31% to $1.10 for the $10,000 of benefit. The judicial benefits higher. The rate decreases pretty similar, 28.6%, but generally the basic life would be decreasing by 30%. Then we have the dependent and the optional life. There are some proposed decreases, so this would be directly to the members. Those would be about 37% decreases, except for the retirees, which has a 20% decrease. But for the child, the proposals keeping the rate the same. There's no one currently enrolled in that. And that's the OSU closed group in that case. Some other benefits, the voluntary A&D and D, that one is proposed to stay the same. Experience has been, I think, if I remember correctly, a little bit worse for that, so it doesn't have quite the reserve buildup. But then disability down below, you can see some of the proposed changes based on short-term disability. Again, about 30%, 31% decrease proposed with some reserve usage, and then the LTD benefits depending on what's available, what you select. The LTD1 and LTD3, which have the 90-day period, those would have decreases while the other two would not. So these were the proposed rates shown prior month. And I guess, if there's any questions around these rates.
Anybody have any questions? Siobhan?
I was just going to ask Greg if you would like a motion made, if you want to go ahead and do these votes.
I was just going to entertain if we had any questions, and then also ask just if anyone would like to make a motion.
Okay, I'm happy to make a motion that we approve the rates as presented.
Okay, I have a motion from Siobhan. Do we have a second?
Second.
Thank you, Sean. I have a second. Any more discussion? Looks like we're saving some money, so that's always good. Hearing no discussion, all in favor of accepting the standard life and disability 27 rate renewal as written, say aye.
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 Any opposed? And any abstention? With that, the ayes have it. Thank you. Emery, go ahead.
Okay, thanks, Chair. Actually, with that, we're going to move into the dental, and I'll turn it over to Emily.
Yeah, hi. Thanks, Emery. So there's no new plan changes to the dental or supplemental considerations since the last board meeting. So I can kind of review these considerations at a higher level. And, there's two options here, and I'll ask you guys what you'd like to do. If you'd like to vote on the whole dental plan as a package, or if you want to just vote after each plan design, I can let you guys decide that. So it's up to you. If you want me to go through all of them and then we can do one vote, or if you'd like to vote for each carrier, just let me know.
Let me just jump here. Anybody on the board have an opposition to allowing her to go through all of them and vote on these as a slate? Unless we find something that we really want to pull out. I'll take that as a yes. So go ahead.
All right, great. Okay, so first up is Delta Dental, and as Emery mentioned, the rate did drop down from 3.4 that we presented last month to 2.1. So their admin fee is still $7.25, which is a 3.3 increase from last year. And again, this slide as we've gone over before, shows 3 benefit considerations. The increasing the annual max in ortho to $2,000 and then adding cone beams. And because the renewal is coming in at above 3.4, it is Mercer's recommendation to decline these benefit changes. So on the next slide. Yeah, thanks. So this one is to allow is to change allowing a separate charge for pulp capping at the time of the restoration to a non-covered benefit. And this is again to protect the member from being billed twice, and then adding bone grafting as a covered benefit. And since both of these have negligible impact, Mercer is recommending to accept these changes. And next slide. All right, so this one is the re-cement and rebond of the crown onlay veneer or implant abutment supported crown. Again, the reasoning for these changes are to encourage the durable treatment and reduce short-term fixes. And this is also to align with the Delta Dental's national policy and clinical standards. So Mercer is generally neutral on this change due to its negligible costs and minimal member impact. However, because it would align the PEBB plan with the DDPA's national policy and simplify administration of the plan, Mercer is recommending to accept these changes. Okay, next one. Thanks. So these first 2 here on the PPO plan, this is to increase the class 1 coinsurance for members who see an out-of-network provider. The first option is to increase it by 5%, second is by 10. And then that third row, the Premier plan, this option is to eliminate the Premier plan altogether, moving all PEBB members to the PPO plan. And so just as a reminder, these are explored as saving options in recognition that the composite was coming in above 3.4. However, because these plan changes would create some member noise and disruption, the plan is already somewhat below benchmark. Mercer is not recommending making these plan changes. All right, next slide. So again, these are the admin changes. They're not benefit changes, just updating language with negligible impact. So the first one is the adding teledentistry. The next one is adding clarification to the domestic partnership affidavit. And then the third one is adding language to the handbook to state that pulpotomy is in conjunction with a root canal is not a covered benefit. Again, no cost impact, so Mercer is recommending to accept these changes. All right, next slide, please. So this is the Kaiser Dental Plan. The change here is to increase the annual max from $1,750 to $2,000. And as Emery mentioned, Kaiser's dental rate did come down from 3.4 to 2.5. So while technically this creates room for this change and enhancement while remaining under the 3.4% threshold, at this time, Mercer's not recommending making this change because the overall composite rate remains above the target, and also increasing the annual max would create parity concerns between the plans. All right, moving to Willamette Dental on the next slide. All right, and as a reminder, after round 2, we went back to Willamette Dental, asking them to provide us with some cost-saving options. And so the first 3 listed here, options 1 through 3, have various levels of savings to lower the rate increase. And then option 4, which is what Mercer is recommending, would be a 3.4 step increase for the next 3 years. And this would be an increase of $517,000 per year and a savings of almost $1 million for 2027. All right, so that is the dental section. Would you like to take a vote to approve the changes before moving on to VSP? Okay.
Yes. So first off, was there anything in those that any of the board members seen that they would like to either ask questions on or pull out separately? If not, I would enter. I was gonna say,
I
if
just
not,
want
I would enter-
to
Go ahead.
comment that my constituents have expressed concern about losing the premier because those are the only ones they have in their regional area that's, they live far away from cities. So those are the only ones offered in those small cities.
Yeah, and we're not recommending removing that plan, so.
Okay.
And if not, if I could have a motion to accept the dental plans as written by Mercer.
This is Siobhan. I'll make a motion that we adopt the dental plan changes and decline the ones as written on each slide from Mercer that was just presented.
Thank you, Siobhan.
I'll second.
A second by, who was that?
Dawn.
Dawn. Thank you. I have a second from Dawn. Okay, on the floor, we have the acceptance of each one of these slides as written and the option selected by Mercer, either to accept or decline. All in favor, say aye.
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 Hi.
Aye.
Any opposed? Any abstention? The ayes have it. Thank you very much.
All right, thank you. Okay, next up is VSP on the next slide. All right, so no new information from last month. Again, VSP is currently in a 2-year of a 4-year rate guarantee. Their admin rate is $1.15. And as Emery mentioned, the increase did drop down from 0.1% to a 1.1 decrease. So there's 3 options total, all of which create cost or member disruption. So it's still Mercer's recommendation to decline and renew as is. And then just a quick refresher, it was the first 2 are to increase frame allowance on the basic plan and add high index lenses with a $20 copay on the plus plan. And then if you want to move to the next slide, you'll see option 3, that was to keep the plan as is and then move everybody to the choice network to create higher savings. And so, yeah, as I mentioned, because of cost and disruption, it's Mercer's recommendation to renew as is. Would you like to take a vote?
Yes. So do we have a motion for the VSP plan?
This is Siobhan. I'll make a motion that we accept the VSP as presented by Mercer, so decline and renew as is.
And a second.
This is Andy. I'll second.
Thank you, Andy. So we have a first and a second. Any questions on the plan? All right, seeing no hands, all in favor for accepting Mercer's decline and renew as is on the VSP plan, say aye.
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 Any opposed? Anyone abstaining? Thank you. That passes. Next.
All right, thanks, Chair. Okay, next up is the supplemental programs. First up, we have ASI Flex and Benefit Help Solutions. ASI Flex on top there with no proposed changes or rate increase. And then Benefit Help Solutions has a 3% rate increase with no proposed changes. Mercer's recommending that PEBB accept both of these renewals. And then I can move to Weight Watchers on the next slide. So as I had mentioned in round 3, Weight Watchers did come in and they lowered the program fee from $32 to $30. And then the program cap is still at 1 million, just over $1.3 million. So it is Mercer's recommendation that PEB accept this renewal as well. And that is it for the supplemental program. So go ahead.
This is Siobhan. I was just going to make a motion that we accept the ASI Flex as presented, as well as the Weight Watchers as presented.
Okay,
And
we have a
benefit
motion.
health. Sorry,
Two, we
and
have-
benefit health.
Oh, sorry. It was ASI and benefit health on that previous slide.
Mm-hmm.
Thank you.
Okay.
This is
Yeah.
Andrea. I'll second.
Okay. So we have a first and a second for the ASI Flex and Benefit Health and Weight Watchers. Any discussion? All right, all in favor of that motion, say aye.
Aye.
Bye.
Aye.
Any
Great.
opposed?
Thank-
Go.
Sorry, I
And-
jumped in.
No, you're fine. And any abstentions? Hearing none, that also passes. Thank you.
All right. Just under, we still got it at before 11:30. So next up, I'm going to turn it over to Andrew to do the next steps in 2 minutes. Oh, you got 1 minute, Andrew.
I think I can do that. They're pretty straightforward. As you can see
we're
here.
11:35. So.
Oh, okay. I've got 6 minutes. Okay.
Yeah.
Good to know. Yeah, so I'll reiterate some of the things that I said at the outset of this presentation. We'll be back with you in June with some more specifics around decisions around achieving 3.4% increase. Between now and then, we'll continue our negotiations with the ASPs, including some of the things that we talked about during the ASP award board meeting in April around meaningful differentiation between the statewide plan and the motor regional plan, as well as some other things that we're negotiating with ASPs. And so I think it's great that lots of decisions were made today on the non-medical and pharmacy renewals. That will make June a little bit easier. But again, if July is needed, then we absolutely can do a July board meeting as well. And so between now and June, we will work on some of those negotiation items with board leadership. We'll bring forward some recommendations this time next month. And we'll see if the board's in a position and comfortable making final decisions, and if not, that's okay. Any questions on where we're at with any of the items that I just went over? Siobhan, I see you got your hand up.
I mean, it's more just as you and staff continue negotiations with MODA and Kaiser for 2027. Just thinking about the providers, particularly, we have a number of providers through the alternative health benefits, physical therapy, massage, chiropractor, naturopathy, all those providers, and the work that needs to happen to bring a lot of those providers on board with MODA and all of the networks that currently serve our folks in Providence is just really top of mind, I think, for us as we make this really huge transition. So just want to name that as you all are continuing those conversations.
Yeah, thank you for saying that. Yeah, I don't know offhand what the network overlap is for alternative care, but that's an especially important care area given some of the issues that have happened with those providers in Providence and the whole sort of ASH network piece. And so, yeah, that area is a particular concern, as well as just more broadly, understanding what the disruption might be and how to solve for that as folks leave the Providence network. Yeah, great call. Any other questions on where we're at and where we're headed, or things to look out for over the next month as we continue to work through negotiations?
If not, as always, I always want to say thank you from the board and all of us, Mercer, each week or each month when you bring these and we move them on. I know you guys do a lot of research and you try to get those numbers where they need to be for us. And we really appreciate the work you've done in all the dental and those extra ones we voted on today. So from the board, thank you very much for your work.
Thanks, Greg.
Anything else before we take a break? We can maybe, is there anything else in your slides that you wanted to hit 100% before we move on?
I won't
Yeah.
be coming back after the break. I've got another meeting at noon.
Okay.
Thanks for joining.
Thanks
Yeah,
for
it's
being
always
here. You can
informative.
let us.
I like to come to these.
We appreciate you being here. It does, it at least gives us you can hear what's going on and hopefully transfer that to
Yeah, back
our
at you.
house.
Yep.
Thank you. Okay, well, with that, let's dump off. What do we got? We'll go 34. So let's just come back at 11:45. I'll give you an extra 1 minute. So I will see you all at 11:45 when the break is over, and we'll start back in. Thank you. All righty. It's 11:45. We'll get started back up. Looks like after the break, we were going to do customer service satisfaction survey results. For OHA staff and Mercer. Maybe.
Great. I believe Sarah should be joining me, but I just saw that maybe she is not in the meeting, so I can just go ahead and get started. For those of you who don't know me, my name is Teslin Ishii with the Mercer team, who specifically works on communications. So I will be going over the 2026 results from the PEBB Customer Service Survey. Just to set the stage, we ran this survey for the month of April this year, and we typically do it annually in the March and April timeframe. So members have a full month to participate in the survey. And as you can see on the slide, we got close to 10,000 responses this year, with similar results from the previous years, ranging between like 15,000 in 2023, 10,000 in 2024, and close to 11 in 2025. So we typically see that 10,000 number being a good average, a good benchmark for how many people we aim to participate in the survey. And I also want to clarify that the way that we structure the survey is that we actually ask people about the services that they received in 2025 instead of 2026, though we know it can be challenging for people to sometimes differentiate, obviously, the service they might be receiving, like at the moment when they're completing the survey versus what they may have received in the past. So I just want to call that out. If you go to the next slide, I'll start with an executive summary of the results, and then we also have a double click down into the specific survey details. And so at a high level, we saw that PEBB members are very satisfied with the customer service that they're receiving across the benefits service department, the benefits team, whether they're engaging in communication questions or dependent eligibility, etc. So we see the satisfaction being very high. You'll see that 81% of people say that they're satisfied just in general with the overall service. 85% say that they find PEBB staff provide timely services as it relates to customer service. 79% say that the staff provide services correctly the first time. 82% are satisfied with staff's overall knowledge and expertise. And lastly, 84% are finding staff to be very helpful. As it relates to communications, we also see people having really high satisfaction. 91% say that they're happy with the methods of communication that are used. 89% are satisfied with the frequency, so how often, obviously, they're getting communications. 87 are satisfied with the content that's being used, and then another 87% are happy with the effectiveness of the communications. So definitely satisfied overall as it relates to the communications that PEBB is sending out, either on a monthly basis or as it relates to open enrollment. And then lastly, in terms of the PEBB website, people are about 89% satisfied with the content, 80% are satisfied with the organization, and a really high percentage of 89 are satisfied with the benefits enrollment system. So I have a double click on all of these slides to show you the exact results, as well as comment on kind of the trending that we've seen. But overall, this is very typical to what we typically see. But if we do go to the next slide, we just have an important call out about some of the timing. So we did administer this survey in April. We know that that was at the time, at the beginning of this year, there was some issues stemming from Providence Health's partnership with Collective Health, and we were hearing a lot about that from members, obviously. So even though we were asking about service that was received in 2025, we definitely see that people were commenting on some of the issues and hardships that they were going through with this partnership and transition. And we saw that people would actually be using the write-in responses, for example, to comment on some of the issues that they had regarding Collective Health. And so we just want to call that out with reading these results with a grain of salt, because that was definitely a very atypical situation that was happening while we were administering this survey. So just important to have that lens on the data overall. And I have some detailed slides where we'll dig into this a little bit more, but wanted to call it out up front. But if we go ahead and click to the next slide, we do like to compare the demographics of who participated in the survey to the actual PEBB population. And so you'll see that we looked specifically at gender and age, and we asked these questions right off the bat in the survey. We had a 70% participation rate in the survey for people who identify as female. This is definitely slightly higher than the general PEBB population. And then age, we see that members ages 45 to 65 participate at a high rate in the survey. This is very typical for what we see year over year. And this is also generally aligned to PEBB's population. So we do like to just take a high level approach to making sure that obviously the respondents are representative of PEBB's population. So we find that they're generally aligned. That concludes the executive summary. And if anyone has any questions on the specific slides as I go through, please feel free to raise your hand or interrupt me. I'm happy to answer questions as we go, or at the end as well. With that, I'll just orient you to how the next slides are formatted. So these are the specific questions from the survey and the detailed responses. So you'll see the orange question at the top, which is the actual question that we asked in the survey. You'll obviously see the graph with the results, and then we do have some key takeaways in the blue on the right side of the page. We also note how many responses were for every question, because there is some skip logic in the survey, and we don't necessarily have as large of a response basis for each question, since all the questions are also optional. So some people may opt into not actually selecting them. So we don't have all 9,700 responses for every question, for example. To begin, we asked people first if they contacted PEBB for any reason in 2025, again, noting that this could be contacting the benefits team for customer service, talking through dependent eligibility questions, asking about communications, or working with program managers. So obviously it depends on how people are contacting staff and what they're contacting staff about, so that we can ultimately rate customer service interactions. And so you'll see that only 31% of people who took the survey actually did contact PEBB staff. So we're only going to go through the results for customer service for those 31% who said yes, they did contact PEBB. You'll see that the results are pretty standard year over year, slight uptick this year, but nothing too substantial. If we go to the next slide, as I mentioned, this will be looking at just the 31% who said that they contacted PEBB. And Rose, yeah, awesome, thank you. This is how did you contact PEBB staff, and you were able to check all that apply, knowing that people may contact PEBB through different channels or multiple times in a given year. So I think no surprise, you'll see that phone call and email are definitely the preferred methods to contact PEBB. Email continues to kind of see an increase year over year, as well as phone call. So nothing too shocking here. And then if we go to the next slide, we asked people what they actually were asking questions about. So if they're obviously interacting with PEBB customer or with PEBB staff for customer service reasons, it's typically about medical benefits questions or open enrollment questions and plan choices. I think that that's ultimately no surprise, and this is what we really do see year over year. We did see slightly more people asking about medical benefits questions this year, and we actually break out vision and dental questions separate from medical. general, and you'll see that these don't even make like the top 8 responses. So people are definitely most curious and needing the most help regarding their medical questions as well as open enrollment. You'll also see things like dependent eligibility verification and just how to enroll, the PEBB enrollment system, potentially issues there. So this is again aligned to what we see, and people are generally contacting PEBB for benefits questions and open enrollment related questions. And then if we go to the next slide, we asked how they would rate their customer service interaction with PEBB staff in the categories that are along the x-axis. So there's quite a few. You'll see we ask about the timeliness of services provided, the helpfulness of staff, the ability to provide correct information the first time, the knowledge and expertise of staff, the availability of information, and then the overall service. And so you'll see, again, this is the percent of respondents who say that they were either very satisfied or satisfied with these categories. So you'll see really high numbers across the board. I think it's important to call out that generally 75% and above of like a approval or satisfaction rating is really phenomenal. People are particularly satisfied with the timeliness of services and the helpfulness of staff, which I think is no surprise given how hard the PEBB staff are working to definitely like work with members on to resolve any issues or help them with any questions that they might have. But I will call out that you see that dark blue line, the 2026 line, is clearly a little bit lower than 2025 and 2024. So this we anticipate is probably due to, again, the impact of the feelings around the Providence Health and Collective Health partnership. And so I'd like to call out on this slide, we actually went back and looked at even like 5 to 7 years of data, and we see little blips like this come and go. Like, for example, in 2020, 2021, the approval ratings were like a little bit lower given what was going on. So I don't think that this is atypical. And we have kind of a hypothesis, as I mentioned, for why that might be. But if we go to the next slide, we also just took this a click further to look at the impact of the Providence partnership with Collective Health. And so you'll see here we looked at non-Providence enrollment, which is the green bar or the left bar, and then Providence enrollment, so members who are enrolled in Providence with the blue bar. And you do see that overall the satisfaction ratings for the people who were enrolled in Providence plans is definitely a little bit lower as it relates to customer service. Again, we're seeing that impact there given what was going on at the time that the survey was being administered, even though we were asking about 2025 when this actually wasn't going on. I think that people obviously wanted to use the survey as a way to voice some of their concerns or their hardships. So definitely just want to call that out, that it kind of explains the data that we're seeing this year. But I do want to heavily emphasize again how high the satisfaction ratings with customer service are overall. I think, again, kudos to the PEBB staff who are providing that amazing service to members. Alrighty, with that, if we click forward, I'll talk now about the satisfaction with communications. So again, these are asking more questions about the communications that PEBB is sending out, and this is going back to our wider population of people who responded to the entire survey, because there wasn't a skip logic to just see who had contacted PEBB staff. So this question is about PEBB's website, asking people how satisfied they were with the organization of the website and the content of the website. And so you'll see 80% are generally very satisfied or satisfied with the organization, and then close to 90 are very satisfied with the content. So we know that there's a lot of resources there for members, and it's great to see that people are obviously satisfied and able to find what they need through the website, whether it's linking to digital tools, the wellness guide, whatever they're going to the PEBB website for. Really great to see those high numbers. And this is very similar to the responses that we've seen over the past few years with people being happy with the website. And then if we go to the next slide, we asked people to rate how satisfied they were with PEBB communications as it relates to the effectiveness of comms. So are you able to understand what we're saying in the communications, the content, what we're saying and how we're saying it, the frequency, so how many times they're getting emails. We obviously know that PEB is sending out monthly newsletters and learning and events. So generally, how satisfied are you with how many emails or how many communications you're getting? And then with the methods used, so whether that's a link to a PDF, a link to an email that we're sending out, the learning and events calendar, a video, etc. And you'll see that the satisfaction ratings are above 87% for all these categories, with members being particularly happy with the methods that are used. And I know PEB has put a really intentional effort into making sure the communications are accessible and in different formats for all different learning types. And so throughout the newsletter, for example, we're sending links to podcasts, to videos that are produced, to actual articles that can be read. So it's just a way, again, to make sure that we're engaging with people in different ways and providing a variety of learning forms to engage with your benefits. So really exciting to see that those satisfaction numbers are as high as they are. And then if we go to the next slide, we ask people how they prefer to receive information from PEB by being able to select any that apply. So you'll see people definitely prefer to get information from emails. Ironically, we also get a lot of survey comments typically that say people feel like they get too many emails. So there's definitely some contradiction there in people's preferences. I know that we all get a lot of emails, so that's no surprise there, but it's exciting to see on this page in particular that things like the enrollment guide, the online plan comparison tool, explore your benefits are also a great preference by members, because PEB's putting a lot of time into developing these tools, making sure that, again, you can learn about your benefits in a variety of different ways and through a variety of different channels. So great to see that people prefer to receive information like throughout all of these. And then if we go to the next slide, we also asked how satisfied people were with PEB's enrollment system at pebenroll.com. And we see that 89% of people say that they're very satisfied or satisfied. This is definitely similar to the results that we've seen over the past few years. So good to see that people are happy with how they enroll and go through, whether it's OE or a new hire, enrolling in their benefits is relatively seamless. So that's great. And then if we go to the next slide, we also ask what topics people might be interested in learning more about. They're able to select any that they're curious about. And so wellness programs is typically at the top of the list. We see people always really interested in like ongoing condition management programs or gym fitness discounts, etc. That's always at the top of the list. And PEB's been really intentional to make sure to, put out a lot of communications regarding wellness programs, since we continuously get this feedback. For example, one of the monthly newsletters was actually a detailed newsletter about how to access your gym and fitness memberships and discounts. And so definitely taking this feedback and continuing to iterate on communications and making sure that we're hitting what members need. And they also say that core benefits, I think, between medical, dental, vision, no surprise that people are always wanting information about that, always continue to want to learn more, as well as optional benefits and general PEB information. So this is overall what we see year over year, but we did see that optional benefits actually decreased slightly this year, and there was generally a little bit more interest in wellness programs and core benefits this year. And then if we go to the next slide, this is actually our last slide, and we just wanted to show you another demographic cut. So as I mentioned, the impact of Providence Health and the collective partnership, or the collective health partnership, we do see that like 61% of the people who took this survey were enrolled in Providence Health. So obviously a majority of respondents here. So that again explains kind of some of the trends that we're seeing. But I just want to emphasize again how awesome the customer service is, and it's great to see these numbers continue to be really high year over year. So kudos to you all. But with that, I will open the floor to see if there's any more questions. Otherwise, we can close out. Yeah, please go ahead.
Yeah, so I just wanted to make a comment, and it's just in line what you've continued to say, is that the customer service really has been exceptional given the environment. And I just want to extend a huge amount of gratitude to the PEB staff who have had to answer all of the calls, because they both have experienced firsthand the impacts of collective health because some of them are on the Providence Plan, or many of them, and navigating with all of the PEB members in this really difficult time. So just huge amounts of gratitude to staff for managing that.
Yeah, I appreciate that, Siobhan, and I just wanted to echo that. I think this shows the resiliency of the PEB brand. You know, just the reputation over the years, and that I think people kind of know what to expect when they contact us, and I couldn't be happier. I was a little bit nervous about this survey, but given the timing, but yeah, it just shines through so brightly. So thank you.
Yeah, thank you both for highlighting that.
Yeah, and thanks,
Oh,
Teslin, so much.
no,
Oh,
thank
sorry,
you.
Sean, go ahead.
I'll just add that, you know, you can really see how quickly trust can be eroded when something breaks down like that. That if we've learned anything, this whole Providence situation has really highlighted that. So the fact that PEB staff has really earned this trust and has sustained it over time, over the years, is really something. That means that it's an ongoing sort of trust building, and that's really great. It's impressive. So please, Ali, just extend our thanks to all the staff, and it's really important. Thank you.
Absolutely. That was exactly what I was going to say, is I know that there's only a couple of you on this call, Ali. So from the board, and I know I probably speak for all of us, as you walk through the room, the building, please let them all know that we appreciate. And I want to thank you, Teslin, and you guys for separating this out and kind of thinking about what was happening and giving us more of a true kind of an idea of where some of these numbers may have came from, which we kind of know that, but it's nice to have it separated out between the Providence members and others to kind of give us that. We really do appreciate that as well, that thought process that you had. And yeah, I've called several times, and everyone I've ever talked to, they're just, they state worker just like I was, and they're doing a great job, and they're just continuing to, love their job, even though some days they may not. They show that in this survey absolutely 100%. So thank you. All right. With that, we are on to.
Looks like we got a comment from Sarah.
We have another one.
Yeah.
Please go
Oh,
ahead.
sorry. Hi, I'm
No, you're
Sarah
fine.
Berthume, and I was supposed to kick this off, and I had a technical issue right at 11:45. So I wanted to tell Teslin, thank you so much, and I also wanted to speak to what everyone else has said, that this survey did a really good job of showing over time how we have maintained our integrity and our trust. And I do have to second what Ali said. We're a little nervous about sending it out during this timing, but also interested to see like what would the difference actually be, and then having it year over year and seeing where members are able to differentiate staff from vendors and the help that they get. And so it was just a really interesting survey, and I wanted to thank staff and everyone else also. And so thank you.
Thank you.
Absolutely. I think anytime you have 10,000 of your members rate you above 70%, you're doing well. And we're in the 80s and 90s, so we're doing amazing. I appreciate that. All of them.
Thanks, great.
Anyone else? All right. We will be on to CL update. Glenn, are you on and available?
Yes, thank you. Thank you, Greg. I just wanted to give folks a short update on the CL May meeting. Greg and Andrea, feel free to jump in there if you have anything to add. First of all, we had a report from our dental carriers, Delta Dental, Kaiser Dental, and Willamette Dental, on their annual dental quality performance measures. The report was for 24 and 25, and it made up of 5 measures. We had them report on preventive service for adults, preventive service for children, a care gap summary, as well as either a diabetic care gap or oral evaluation for diabetes, and then a satisfaction target, or excuse me, measure. There was really no specific issues across the board. They either pretty much met the targets, or were Kaiser was slightly below on several of the targets. We then had the carriers provide, what are you going to do to improve? Because we're always looking for our vendors to improve on these measures, even if they're kind of right at it. And so they provided their action plans for that the upcoming year. One thing to keep in mind is that we will be, as part of the CIAO Summer Research Group, we are going to be looking at our dental measures, and as well as identifying measures for access, and then looking at other factors such as equity for the dental measures. That leads into the next item that CL looked at, which was the Summer Research Group. It's actually kind of broken into 2 topics. It's, as I mentioned, the dental measures will be the first topic that we'll look at. And then we're going to look at cardiovascular care optimization. That actually came from last year's summer research group. It was identified that we needed to really kind of look at coming up with a way to measure the reporting framework for measuring to better understand really the utilization patterns of drug combinations, and how these utilization patterns really align with HB1AC improvement. In the December CL meeting, Mercer provided their initial findings from the carriers, and it was determined that really that they needed subsequent presentation would be necessary for that. So bottom line is, for that part, is we will be looking at what was identified as cardiovascular care optimization, looking at 3 pillars, and then how to get that really to achieve that cardiovascular care optimization. There will be 2 meetings a month, June through August, for that. And we are going to be sending out an email. We will generally, what we do for these research groups, we'll have representatives, carriers, Mercer staff, as well as 1 to 2 OEB and 1 to 2 PEBB board members. Right now, we do have 1 volunteer for the cardiovascular care, and you can either volunteer for cardiovascular care or the dental, or both. So I guess what I'm just kind of say is, if you have any interest, give me an email or give me a call, and we certainly can sign you up for that. Before I go on, are there any other questions right now? Okay. We also had, which kind of relates to, the cardiovascular care, and in the what we were looking at, the updated HB1AC reporting. It was identified from the last year's CIAO Summer Work Group to develop a framework to better understand the combinations, as I was mentioning earlier. We had the initial findings in December, and then over the past several months, Mercer worked with the carriers to streamline the reporting framework. And basically what these updated reporting found is that utilization patterns vary across carriers with notably higher utilization rate of GLP-1s in Moda and Providence, while Kaiser had a higher use of metformin. Uncontrolled diabetes was present across carrier populations and access categories of member complexity and across, categories of member complexity and comorbidities. So it wasn't, kind of specific for any one carrier. High utilization of GLP-1s was seen even in members with fewer comorbidities. And then proportionally more utilizers of GLP-1, it made improvement in glucose control from than the utilizers of metformin only. And the impact is generally most significant with complex patients. Those were the three items that we were looking at. In June, we will be electing a new chair and vice chair for CL. Will be the primary focus of the June meeting. Is there any questions? I know I got kind of a couple of those items a little mixed up. Anything to add, Greg or Andrea?
No, I think you covered it well. Andrea? Nope. Thank you, Glenn, very much. We appreciate it.
Okay. Thank you.
Right. The HEW update. Sharna?
Thank you, Chair. Hi, everyone. I'm Sharna Freehan. I use she, her, hers pronouns, and I am the staff lead for the Health Equity Work Group, which consists of, as you know, Mercer consultants. We have 5 board members, 2 from this board and 3 from OEB, and we are working currently on our strategic plan. It has now been adopted, and we are actually working on our tactics for 2026. And one of our tactics was to participate in the 2027 renewals for PEBB. That would be, of course, the things we were just talking about: the dental, the vision, the life and disability, and all those other supplemental programs, and looking at actual health equity elements of those programs and asking for improvements in those particular programs. So that was one of the things that we had done in 2026. And what's up on the screen right now is something that we're initiating right now as of this month, is to look at the Garner program through the health equity lens, and also trying to identify a Kaiser Permanente program that is similar, because of course, as you know, that closed system doesn't have the same sort of like referral process and higher ratings and that sort of thing. So we were looking for something that was at least somewhat relatable. And the other thing that we picked up was monitoring the Kaiser Permanente doula network, because it's a little less robust than might be needed. Rose, can we go to the next slide, please? Thank you. So with the Kaiser Permanente, we're checking to see if they're collecting data for the Center for Black Health and Wellness and the Spanish Clinic, and to see if we can, what kind of data they've got, how we can analyze it, and what it means for our members, so we can identify if there's some health equity issues or even wins that we're doing that we can highlight. Next slide, please. So the doula and birth networks adequacy is a little more complex. So we're looking at mapping the current network and where the doulas are located. We're going to get some updated utilization records and apply that health equity lens to it by getting some demographic information crosswalked with that. And we're also going to look at those denials, make sure there weren't any denials for an incorrect reason. Also, we are going to be providing information on a Kaiser collaborative with this county healthy birth initiative and other programs and groups. So we're going to see if they're actually utilizing these resources and if they're referring some of our folks to it. That's just sort of give you an idea of the kinds of things that we have to look at to actually measure health equity and some of those tactics that we're employing this year, knowing that next year, especially for PEBB, while we may have some of the same carriers, what we offer and how we offer it and how it's accessed is likely to somewhat change for our membership. So that's just kind of a bird's eye view of what's going on right now. Are there any questions? Okay, thank you for your time. It's always great to come in and share with you what's going on with our group. Thank you.
Thank you very much, Sharna. It looks like we're doing very well on time. Mercer, I know there were some slides you missed. Was there anything else that you felt that we needed to know in this meeting before we move on? We have a few extra minutes. Hearing
I think we're
none.
all set, Greg. Yeah, I think we're
All right,
we're good.
thank you very much. Any other business or comments? We have one hand. Freeman, go ahead.
Thank you. I'm sorry. I forgot to thank Glenn for bringing up the summer CL work group. The health equity work group is going to be participating in that. He did mention the health equity elements of the work group for the summer, and we're really excited to collaborate with CL and hopefully in the future with IWG to make sure that we can offer those perspectives. Thank you.
Awesome. Thank you for that. Anything from the board or anyone else? Rose, is there any public comment?
I don't believe so. She didn't get back to me saying she would definitely comment this time, and other than the 15 you got written comments, I don't think.
Yeah, please take a look at the public comments. You know, they're always informative. Again, it's a good way to have a good idea of what's happening with our members, and you know, it's really great that they take the time to put down their thoughts and give them a voice in front of the board. So thank those members.
Absolutely. Siobhan?
Yeah, I just wanted to comment on the public comment as well. So thank you for that, Ollie. I know that while the numbers have gone down, we don't have as many public comments as we did last month. We still see some pretty egregious issues with collective health, and we know that we're having issues with providers getting paid, and that directly impacts our members. And we're particularly seeing that around the alternative care that came up earlier in the conversation. And at one point, when we were dealing with ASH prior to collective health, this was, I forget whether it was in the fall, we were getting information from Providence around providers that had been dropping, and it might be helpful for us to have that perspective again. And just as part of the effort to have MODA looking at these different providers, as we know that people are going to onboard into MODA in 2027. But we know that this has been an area, particularly with small providers, that we've seen a lot of providers not getting paid, which is just not acceptable. So want to lift that up and how that is impacting our members.
We can bring that back, Siobhan. Yeah, we could provide an updated report on the providers within the ASH network and any change since the last report to the board.
Thank you. Kimberly?
Good afternoon. I just wanted to comment again that I had members and providers reaching out to me because they knew that I was going to be at this meeting, and they're still not getting paid. So they said that they were told that they're working on current month and they'll eventually get to the backlog, and they're not getting paid. So and people's EOBs aren't coming through and those kind of things. So just wanted to go on record that it continues. And my fear is that we get to the new year and then that just gets swept because they don't exist for us anymore. So thank you.
Thank you.
We'll put together a status report, Kimberly, from Collective Health and vetted through staff and send that out to the board, including the number of providers. Shouldn't take too long to put together. I appreciate you bringing that.
All right. And Sean?
Yeah, several times throughout the meeting, the issue of just alternative care, alternative medicine has come up, as far as reimbursements, but other topics as well. I just wanted to flag this, for our future board discussions or maybe innovation work group, but there's some evidence that's reasonable that that alternative care can save costs, particularly in certain groups, like for example, certain types of emergency room frequent flyers or urgent care, migraines, that kind of thing. So I just want to flag it. We have a problem right now that they're not getting reimbursed, but it sort of brings up the topic, right? And I know Emily's mentioned this a few times in the board meeting. We've talked about it just for briefly, but I think it's worth really looking into it. That this is part of our portfolio, and are we leaning into it? Are our plans leaning into it as much as they could be for some real benefit of diverting some relatively major costs? I'm not saying that that's the only, that's where you need to go if you're having a heart attack or something like that. But for some conditions that are particularly vexing, migraines or things that end up in the emergency room, kind of those kinds of conditions, it has been found to be pretty effective to do some of these different models. And so I just kind of wanted to flag it since it came up several times. It's actually a really important piece of our, portfolio, and it might be worth taking a look at it. Are we using it to its best? Are we saving as much as other states have saved in implementing it the way we are? There's been some studies of some fairly dramatic cost savings, and I'm not a data analyst in this area, so I don't know, caveats and whatever, but it feels like a worth deeper dive at some point when we have a minute, which is not now, but just wanted to flag it. Thanks.
Thank you, Sean.
No, it's very true. There are a lot of studies that show that even surgeries have been prevented, which are very expensive. And so just by doing physical therapies and those things outside of what people consider traditional medicine. So no, I appreciate that very much. I've got to skip through here, but anyone else? Take a look and see if I have any hands. Seeing none, thank you all for the 2 meetings, some of us today. Appreciate you all being out on a great day today. And enjoy your rest of your afternoon. And with that, we will adjourn the PEBB meeting for today.
Thank you all so much. Take
Thank
care.
you.
Thank you.